Hola, ¿qué tal? ¿Cómo están? Buenas noches. Qué gusto que estemos otra vez reunidos en este último día del Summit de Alergia a Medicamentos 2021, que fue la última actividad de Compedia. Les recuerdo que el día de hoy, al final de la sesión, por favor contesten la encuesta para poder obtener su constancia. Y es para mí un placer presentarles a la coordinadora del día de hoy, la doctora Elizabeth Estrada Reyes. Ella es alergóloga pediatra egresada del Hospital Infantil de México. Es una gran colega y Eli, te quiero felicitar y te quiero agradecer públicamente el que nos hayas ayudado. Fuiste pieza indispensable para la realización de este Summit de Alergia a Medicamentos, así como para la Semana Mundial de Alergia. Te dejo con la audiencia y solo les recuerdo que para la traducción de las pláticas tenemos el icono de interpretación y se puede escuchar en simultáneo en español. Eli, es todo tuyo a la audiencia. Muchas gracias.
Hola, buenas noches. Ya estamos en el tercer día. Muchísimas gracias, Benja, por la invitación. La verdad es que creo que pues fue muy enriquecedor porque realmente creo que sí aprendimos bastante. Espero que sí esté llenando, digamos, como todas esas expectativas y dudas que tenemos sobre alergia a medicamentos. Y pues bueno, vamos a empezar con la primera charla, que la doctora Lene Heise Garbi, y ella nos va a hablar de alergia a betalactámicos. La doctora es profesora y doctora en el Anesthesia Allergy Center, desempeñando las funciones en la clínica de alergias del hospital Getafe Hospital y en el Departamento de Medicina Clínica de la Universidad en Copenhague. Ella tiene la especialidad en anestesiología y tiene una subespecialidad en alergia. Es cofundadora y médica en jefe del Danish Anesthesia Allergy Center, el Centro Nacional de Referencia para la Investigación de Hipersensibilidad Perioperatoria en Dinamarca, establecido en 1999. También es vicepresidenta de la Sociedad Danesa de Alergología y miembro de la Junta del Grupo de Interés sobre Alergias a Medicamentos, del IACI, y es miembro activo de varios grupos de trabajo de IACI que actualmente incluyen pruebas de provocación de medicamentos y pautas de anafilaxia. Ella también tiene muchísimas publicaciones también en anafilaxia. Entonces, pues empezamos con la plática de la doctora Lene.
Good evening, and thank you to the organizers for inviting me to speak at the Drug Allergy Summit for Compedia, Mexico 2021. My name is Lena Heise-Garvi. I'm an allergist in Denmark. I'm a consultant at Gentofte Hospital Allergy Clinic, and I'm the head of the Danish Anesthesia Allergy Center. Today, I will be speaking to you about perioperative allergy, and I'm heading the Danish Anesthesia Allergy Center in Gentofte, Denmark, where we've been working with perioperative allergy for a long time. If we talk about perioperative allergy, there are some special problems compared to other parts of drug allergy. Reactions in perioperative allergy are rare. The incidence is something like 1 in 5,000 to 1 in 10,000 anesthetics. The diagnosis is difficult to make. Some of the symptoms, like bronchospasm and hypotension, mimic the normal reactions you see at anesthesia induction. And there are many differential diagnoses to perioperative allergy. You also have a situation with lots of different drugs being administered at the same time. And there are things that you may not expect to be allergens, so hidden allergens like the disinfectants, some of the excipients, that no one necessarily thinks of as potential allergens. So basically, perioperative allergy investigation, I usually say, are the most complicated patients in drug allergy investigation. It requires, to do this investigation properly, it requires specialist knowledge of what happened at the time of the operation, so in the perioperative setting, and that's what the anaesthetists are specialists in. And then it requires knowledge and experience with allergy testing, and that's what allergists, immunologists, dermatologists are specialists in, depending on the country. I'm specialized in both, so I'm a specialist in anesthesiology, and I'm also a subspecialist in allergology. So I've got both specialties, which is why I've got this particular interest in perioperative allergy. The other thing about this, because the reactions are so complicated and the patients are so complicated, it requires a number of patients each year to actually get enough experience to do this type of investigation properly. And in the EAACI guidelines, we recommend a minimum of 20 patients a year for someone to build up enough experience in this field. When you're looking at perioperative allergic reactions, so a clinical picture suggestive of perioperative allergy, so a patient who has a drop in blood pressure, tachycardia, potentially respiratory problems, potentially some skin symptoms during an anesthetic and an operation. What we're mostly obviously interested in is identifying the IgE-mediated reactions. Those are the ones where there's a big risk of this recurring, if people are exposed to this allergen again. The other mechanism, there are many other mechanisms in drug allergy. I'm sure you'll be hearing about this in other talks during this summit. Many other mechanisms, such as specific receptors on the mast cell complement COX-1 system and all those, and they will be mimicking allergic reactions. However, there are also in the perioperative setting a number of reasons why your blood pressure might drop or you might develop bronchospasm, which have nothing to do with allergy. And in the 2019 IACI position paper on perioperative and hypersensitivity, we've listed some of these potential problems. So if you have just hypotension during anesthesia without a tryptase increase, it might just be due to uncontrolled bleeding, other types of shock, bone cement implantation syndrome, even relative overdose of the anesthetic agent. An isolated bronchospasm is mostly due to undiagnosed or undertreated asthma. An angioedema could be due to the patient being on an ACE inhibitor. So you need to be aware of all these differential diagnoses in the perioperative setting, which have absolutely nothing to do with allergy. And then you won't find a culprit on investigation. I've been referring to these guidelines, or the EAACI position paper on perioperative hypersensitivity investigation. This is a task force that I was lucky to lead, and it's a combination of allergists and anaesthetists. So we had people who were experts from all these different countries in Europe join in and contribute to these guidelines. And they are the most recent and updated guidelines on perioperative allergy investigation. There are also other, now relevant for Mexico, other countries, Spain and Brazil, that are already active in perioperative allergy investigation. And what is important is that you get the collaboration between anaesthetists and allergists, like I already mentioned. We also have an international network, the ISPAR group, the International Suspected Perioperative Allergic Reaction Group. And we published a number of papers in the British Journal of Anesthesia in 2019. And this is actually a network that's open for everybody. So everybody, allergists, anaesthetists, immunologists who are interested in perioperative allergy can join. And this is the website that you can go into and actually join the ISPAR group if you're interested. One of the papers that we published was this management of suspected immediate perioperative allergic reactions. This is basically guidelines for anaesthetists in how to diagnose and treat perioperative allergic reactions. Now, just to tell you a little bit about what we do in Denmark. So we have the Danish Anesthesia Allergy Center as the only national reference center in Denmark. We're a population of 5.8 million, and we've been recognized by the Danish Board of Health as the only center to do perioperative allergy investigation in Denmark. We obviously mainly investigate patients with suspected perioperative allergic reactions. We've done that for over 20 years, and we have a completely integrated anaesthetist and allergist service. So the clinic is in the allergy clinic, but we have anaesthetists, myself and two others, employed in the allergy clinic. So we have conferences and we discuss every single patient, and we actually test patients every day. The one thing that is probably differs in our center from most other centers is that we do, in addition to the other tests with skin testing and in vitro tests, we do drug provocation tests in all patients that come through our center. And this is the setup. We have this special room where we have possibilities of obviously monitoring and close surveillance with the doctors and nurses in the actual room. We published these, which are actually more or less condensed guidelines, algorithms for investigation of perioperative hypersensitivity. And this was basically, we are the three people in the Danish Anesthesiology Center, and we've got Didier, both from Belgium, and Michel Mertes, who's been very instrumental in the whole perioperative allergy investigation in France in this actual paper. But these are a brief overview of and with algorithms of how to investigate perioperative allergic reactions. So those are recommended. In the Danish Anesthesiology Center, we will investigate all patients with what we suspect it to be allergic reactions. So even patients with just urticaria, we will investigate if we think that could be a relevant reaction. We also have some things that we test all patients with, and that's latex. It's the disinfectant chlorhexidine, which is used in Denmark, sterilizing agent ethylene oxide, several excipients, and lidocaine gel, which is often used in the perioperative setting without being documented. So we actually test every single patient for those. We also test in different test modalities. So we will do both in vitro testing, a skin prick, an intradermal testing, and a drug provocation if the other tests are negative. And we've done that since 2004 for all drugs, even the hypnotics such as propofol, remifentanil, the opioids. And we've even since 2016 also done provocation in a 1 in 10 dose with up to a 1 in 10 dose with the NMBA, so the neuromuscular blocking agents. We conclude investigation to be positive for a specific drug if we have more than 2 test modalities, or 1 or 2 or more. So we have, for instance, a specific IgE for a penicillin and a positive prick test. Then we say we're sure that this is a true positive. Or if all the other tests are negative or inconclusive, then we can make the diagnosis and provocation. If all test modalities are negative, there's quite a high negative predictive value in testing in different test modalities and finding them all negative. So the investigation protocol starts with detailed information of what went on in the operating room. So detailed clinical information, and then in vitro tests, and here the tryptase test is instrumental. So you have to have a tryptase from the time of reaction, or you don't have to have it, but it's very helpful. And in Denmark, we sent this box of blood sampling kit out to all the anesthetic departments, and that increased the number of referrals where we did get a tryptase sample from 40% to over 80%. It is important to get a tryptase because of all the differential diagnoses that are actually not anything to do with allergy. So the tryptase will be helpful in distinguishing between true allergy and some of the other non-allergic diagnoses. So we use allergen-specific IgE when available, which is for the penicillins, for chlorhexidine, for latex, for ethylene oxide, but most other drugs you don't have. There is no access to an allergen-specific IgE. In those cases, basophil histamine release or basophil activation can be used, but that obviously requires quite a specialized lab. In vitro tests are skin prick test and intradermal test. They're still the mainstay of testing in the most of the world for perioperative allergy. And as I said, we additionally do drug provocation. So I said that the clinical information is very important, and we do not rely on a referral letter. So a referral letter of someone saying these are the drugs you need to test is not enough. You need to have the anesthetic chart, you need to have the surgical notes, you need to have the surgeon's operating, description of the operation. You need to sometimes even contact the operating department to find out what they exposed the patient to. You have to have a copy of relevant medical notes, because your aim is to identify all the exposures that occurred before the reaction happened. As I said, the tryptase is very important. Tryptase is released in IgE-mediated reactions. And as you can see here, the tryptase has a nice dynamic in that the peak is about an hour after the reaction onset. And that means you can actually stabilize your patient before you have to think about a blood test. Histamine is no use. We do not use that, but tryptase is very important. And what is important to know is that you do not anymore use absolute cutoff value. There's a new algorithm where you have to compare with the patient's own baseline. That has to be taken a minimum of 24 hours after the reaction. And we actually take the baseline after the reaction, obviously, but at the time of allergy investigation. And basically, what you need to look at is whether the reaction tryptase is higher than the baseline, the patient's own baseline, times 1.2 plus 2. So, for instance, if the baseline, if the reaction tryptase is 9 and the baseline tryptase is 2, then you have 2 times 1.2 is 2.4 plus 2 is 4.4, and 4.4 is less than 9, which means that that reaction tryptase of 9 is actually clinically relevantly elevated. And there's this paper from Jackie in Practice by Joanna Witte and a few other experts, including myself, which is very helpful in learning about tryptase in the perioperative setting. Skin testing is it's very important to do it in the right way. So doing the intradermal test in the right way, interpreting the intradermal, especially the intradermal test in the right way, and using the right concentration. And all this is in the Jackie position paper from 2019. The concentrations in here for skin testing are the most updated and the ones I recommend that you use, especially for things like neuromuscular blocking agents, because we have a consensus from all these different Europeans about these concentrations. So please go for this paper if you want to do skin testing for perioperative allergy. Just very briefly about drug provocation. As I said, we do that in Copenhagen or in Gentofte. It is not something that's done a lot around the world, but we do it. We use the route of administration, which was in the original reaction. And that means that in perioperative allergy, a lot of the drug provocations are intravenous. It's actually quite, if you have the right setup and you do incremental dosing of 1 in 100, 1 in 10, and a full dose for things like antibiotics, it's actually quite a safe way to do it. Where we do it, we have the patient monitored while we're doing it, especially for the anesthetic drugs and the opioids and the drugs with special sort of effects that you don't see normally in drug allergy. And some drugs, such as propofol, the hypnotic drug, remifentanil, fentanyl, the opioids, and the neuromuscular blocking agents, our maximum dose will be 1 in 10. So we will not go up to a full dose because that would mean that we would anesthetize the patient or paralyze the patient. So we have a very careful provocation model for neuromuscular blocking agents, and it's actually the anesthetist in our department who administers the highest dose, the 1 in 10 of therapeutic dose. And that's proven quite a safe protocol, but definitely not something that people who are not experienced in this should do, and definitely not without anesthetists present. So when we do these provocations, as I said, we have full monitoring, we have close observation for signs of allergic reactions, and obviously full resuscitation facilities. So drug provocation in perioperative allergy is only for highly specialized clinics who have the expertise in perioperative allergy investigation, who have the access to anesthetists and collaboration between anesthetists and allergists. There's another paper in the British Journal special issue on perioperative allergy, and here we wrote one of the first papers on drug provocation testing in perioperative allergy. So if anyone is interested, that's the paper to go for. Now I'll just present you with a small case. This is a case that we had some years ago, a patient who had to have a ureteroscopic stone removal in general anesthesia. He denied having any allergies when asked by the anesthetist. Anesthetic induction was uncomplicated, but just after they gave IV topramycin, he suddenly had tachycardia, hypotension, generalized redness, and decrease in saturation. Absolutely no discussion about this being anaphylaxis. They tried ephedrine, which obviously didn't work because adrenaline is the drug of choice in perioperative anaphylaxis, as in all other anaphylaxis. There was a good response to the adrenaline, and the patient stabilized over 10 to 15 minutes, but the surgeon was asked to finish the operation faster than he would have liked. The patient wakes up, and there's a lot of people around the bed, and they say to him, "Are you sure you don't have any allergies?" And he says, "Oh, actually, I seem to have had a rash last time I had an operation. I just forgot to mention that." Anyway, the surgeons decided that tobramycin had to be the cause because it happened just after injection of tobramycin. The patient had some diabetes, high cholesterol, hypertension. He'd never had any allergic reactions, no hay fever, no reactions to drugs or foods. But he had a rash when he had blood taken the previous week. He noticed that his elbow got quite itchy after he had the blood taken. And then he had this urticarial reaction in recovery after some minor urological surgery the year before. Now, tobramycin was not administered during that surgery, and he actually had a picture. This is a picture of the patient, and this is urticaria, very clearly urticaria on his neck, on his chest, and it was also further around on his body, on his arms, and on his abdomen. But he hadn't really told anyone about this. He'd just taken this picture. So we had a blood sample taken for tryptase, and as you can see, the tryptase 55 minutes after the reaction. It's important to note at what time the tryptase is taken, because as I showed you before, there's this dynamic increase, and you need to know where you are on that graph to interpret the tryptase properly. But the tryptase taken about an hour after the reaction was highly elevated at 26.7, and his baseline was 4.3. You don't even need to do the algorithm to see that this is elevated. Specific IgE analysis can be done on the same sample as the tryptase. We sometimes do this when we want a quick result. It was negative for ethylene oxide and latex, but it was highly positive to chlorhexidine. Now, a single test like a specific IgE is not necessarily enough to conclude that there's an allergy, but it certainly was very suggestive, and the patient had had 2 reactions. And even though tobramycin was suspected in the first reaction, actually tobramycin had not been administered during the first surgery. So chlorhexidine was a likely culprit. And in fact, when we did investigate the patient, skin testing, both skin prick and intradermal tests were positive for chlorhexidine. We therefore have 3 clearly positive tests for chlorhexidine. We have also a clinically significant allergic reaction. So, and we also then tested all the other exposures, all the other things he'd been exposed to, and they were all testing negative. So the conclusion here was that the patient had allergic reactions to chlorhexidine actually twice. And we often see these milder reactions before we diagnose chlorhexidine allergy with an anaphylactic shock. And really, this is one of the reasons why we investigate milder reactions, because if we pick up chlorhexidine after if he'd had it picked up after his urticaria in recovery, we could have saved him anaphylaxis at his subsequent surgery. These are the results from our Danish Anesthesia Allergy Center investigations. And you can see here, this is from 2004, when we started doing drug provocations, till now. Nearly 750 patients, 365 positive tests in 332 patients. So 44% of the patients test positive, which means that there are quite a number of other causes of perioperative anaphylaxis. Partly all the other mechanisms like the MR-GPRX2 receptor that can be activated by certain drugs, but also these non-allergic differential diagnoses such as bleeding or epidural that's very makes the blood pressure drop, or undiagnosed asthma and all those. But what is interesting is that chlorhexidine is actually the most common single allergen that we see in our center. So about 9% of our the reaction in that we see, the positives are chlorhexidine. The next most common, well, the most common drug group is antibiotics, and this is actually similar to most other countries in the world. It depends what antibiotics are being used. Cefuroxime was used a lot, penicillins are used a lot, and at the moment we have piperacillin tazobactam as one of the ones we see most commonly. But antibiotics are used in almost all surgery, and therefore we see reactions to the antibiotics. We also see a number of reactions to patent blue, the blue dye that's used during surgery for sentinel node surgery for breast cancer, and we see quite a number of those. And then the neuromuscular blocking agents, which are the most common cause in many countries. We don't see that many reactions to those. And actually, more and more countries now have antibiotics as the most common cause, and some countries have the neuromuscular blocking agents. But if we go back to chlorhexidine allergy, chlorhexidine really is an allergen you must not miss in the perioperative setting, because certainly in many countries, all patients are exposed to chlorhexidine one way or another. If you don't use it as a skin disinfectant, it might be used in urethral gels and various other things. And as I said, the mild reactions, previous mild reactions may increase suspicion. It should be tested in all patients with skin testing and specific IgE if possible. And these are the concentrations for skin prick test and intradermal test that we use in our center, and that is also recommended in the AACI position paper. And if you have a positive prick test and a positive specific IgE, you have more or less 100% likelihood that this is a true positive. What you need to be aware of is that the specific IgE levels are dynamic. So here we have a patient who has a reaction at this time. He has an elevated IgE for chlorhexidine at that time. It increases after the reaction, decreases again. He has another exposure to chlorhexidine where it increases, but then it actually decreases down below the 0.35, which is the normal reference for specific IgE. So you cannot conclude that specific IgE, that there is no chlorhexidine allergy just because the specific IgE is not elevated. So you have to be careful about that. But you can do, like we did in this case, you can sample chlorhexidine at the time of reaction, which is quite helpful. Chlorhexidine, as I said, certainly in the Danish health service and in many European health care environments, is very, very widely used. And we had a PhD student, Morten Opstrup, who did a PhD on chlorhexidine. One of the things he did was a follow-up study of the patient who had been diagnosed with chlorhexidine, and he could see that a third of them had been re-exposed in the healthcare sector to chlorhexidine. None of them had been exposed in the home. They were very good at avoiding chlorhexidine themselves, but they'd been re-exposed in the healthcare sector, and in fact the urethral gels were probably the most common cause of re-exposure. In Denmark, and certainly in our region, they've taken chlorhexidine out of these urethral gels because there's no evidence that you need a disinfectant in urethral gels generally. Latex allergy is interesting. In Denmark in 2004, the National Board of Health came up with some recommendations about latex allergy because there was a massive increase in latex allergy in the 90s. And in Denmark and in many other countries, some measures have been taken to try and decrease the risk of latex allergy. So there's an increased use of latex-free products. They use more refined products of latex with a lower protein content, and they've stopped the use of powdered gloves because the powder would make the latex particles fly around the room, and people are likely to have been sensitized via the inhalational route. So latex allergy, so that's sort of primary prevention, but secondary prevention also by doing latex-free surgery for patients such as spina bifida patients or children who had multiple surgery in their childhood. And that's also decreased the number of latex allergic patients that we see in the healthcare sector. So if we look again, here you can see latex is there are not very many latex allergic patients in our center. And when we look at when they were all diagnosed, we had, you can see here 12.4% positives in the period 1999 to 2003. That decreased to 2.8% in 2004 to 2012. And then we had a period where we didn't have a single latex positive patient. And between 15 and 17, we had 4 patients. But if you look at the period between 2010 and 2017, we were down to 1.8% of the patients actually reacting to latex, or the positives being latex. And since 2018, we haven't seen a single latex allergic patient. So all these things that the Board of Health recommended have certainly had an effect. Now, last thing, local anesthetics, very often suspected by patients and by healthcare professionals. We have looked at all our data between 2004 and 2013, over 200 patients, all with provocations with all the different local anesthetics, all negative. So, and we've done the same with our dental patients in the allergy clinic. We haven't found a single case. We have found one case of allergy to lidocaine in a perioperative setting, but one case out of 750 and over 20 years. And I don't expect actually to see any more. It's an extremely rare allergy. So the vast majority of patients suspecting local anesthetic allergy can have that allergy disproved. So in conclusion about perioperative allergic reactions, they are very rare. There are many non-allergic differential diagnoses. You don't have to operate with this in normal drug allergy, but in the perioperative setting, there's all this bleeding and undiagnosed asthma, airway hyperactivity, all this sort of thing. Tryptase is therefore extremely important in the perioperative setting. It has to be taken ideally at 1 hour after the reaction. If you take it later, please note the time you've taken it. And then when you interpret it, compare it with the patient's own baseline and see these even discrete elevations might be relevant. And then the patient has to be referred for investigation. And really, this type of investigation needs to be carried out by people who know what they're doing as a collaboration between allergists and anaesthetists in specialized centers. This is not something that any allergist should set up to do. It is something that should be done and concentrated in specific centers. I just want to advertise the first masterclass on perioperative hypersensitivity, or the first international meeting, physical meeting ever in perioperative allergy. That's going to take place in Verona in Italy in April 2022, and you're very welcome to sign up for it. Registration will open shortly. Thank you very much for your attention, and thank you again to the organizers for inviting me to do this talk.
Ok, y agradecemos la plática de la doctora Lene. Solamente una corrección que teníamos es que primeramente nos dijo que quería darnos la charla de alergia a betalactámicos, pero corrigiendo es la alergia perioperatoria. Sus preguntas les agradeceremos que si nos las ponen en el chat y nosotros se las vamos a hacer llegar a la doctora Lene y posteriormente los contactaremos a ustedes. Ahora, seguiremos con el programa. Nuestro siguiente ponente es el doctor Davide Caimi, con el título de Protocolos de desensibilización rápida a fármacos en población pediátrica. El doctor es especialista encargado del Departamento de Neumología en la División de Alergia en el Hospital Arnaud de Villeneuve y el Hospital Universitario de Montpellier, Francia. Y bueno, pues empezamos con la charla.
Hello, and thank you for inviting me to talk to you about this topic. My name is Davide Caimi, and I work at the allergy unit of the University Hospital of Montpellier in France. And I will talk to you today about desensitization protocols in children. I have no conflict of interest for the presentation today. So we will go through a few questions and we'll try to answer to them. First of all, when should we think about a possible desensitization protocol in children or in general? Well, when you have a patient who comes in your office and you need to perform an allergy workup for drug allergy or drug hypersensitivity, you always need to start collecting the clinical history of the patient. For some drugs, you also may be able to do some in vivo and in vitro tests, but most of the times you need to go to a drug provocation test. So drug provocation tests are different from desensitization protocols. In the first case, the hypersensitivity reaction has still to be proven. With desensitization, it has already been proven. So drug provocation test is a mandatory previous test that need to be done before desensitization. The goal in the first case to confirm or to exclude hypersensitivity reactions, and in the second case, to provide the patient with temporary tolerance. So the starting dose is very different because in the desensitization protocol, we saw at very lower doses and we reach the final dose through more steps than with the usual DPT. And also, if the patient has a reaction, with DPT, we stop the test and we treat the patient. And we know that the patient is allergic to the drug. In case of a desensitization protocol, we stop the protocol, we treat the patients, but then we start again because we need to provide the patient the final dose. So in the first case, we're talking about a diagnostic tool, and in the second case, a therapeutical tool. With desensitization protocol, we reach tolerance in about 4 to 12 hours, and the tolerance to the specific drugs lasts only for 3-4 half-lives of the molecule. And when we stop the administration, the tolerance is lost. And so for the next dose, for the next cycle of treatment, we need to re-propose to the patient another desensitization protocol. They actually have been published for any age, from children to adults. But when we should actually propose such therapeutic approach to patient, well, we have the drug provocation test. At the end of it, we can say the drug is safe for you, so you can take it home. Or the test is positive, so you need to avoid this drug. And possibly we find an alternative that could actually fit to the case. Nevertheless, when there are no possible alternatives, or if they are less effective or even noxious for the patients, or in those cases in which there are few drugs available for our disease, or if the drug is essential, in that case, we need to propose a desensitization protocol. So what are the drugs that we can propose for desensitization in children? Well, DSS protocols are indicated after a careful assessment of risk and benefits. We could propose them to patients suffering from severe and chronic infectious diseases, such as tuberculosis, HIV, cystic fibrosis, or patients with hematological or oncological conditions, with chronic inflammatory diseases, and patients who reported an hypersensitivity reaction to vaccines. So in pediatrics, we mainly focus on antibiotics, especially beta-lactams, NSAIDs, chemotherapeutic agents, or monoclonal antibodies, and a few others. Is there a contraindication? Of course they are. So let's see the history of Julie. She was at the time 13 years old. And what happens to her is that on day 1, she presents fever and she takes acetaminophen. On day 3, she presents pneumonia and starts vomiting. So they start treatment with ceftriaxone. Day 5, fever is gone. So everything seemed going better, except that at day 10, she started presenting generalized erythema, still under treatment with ceftriaxone. And the following day, she has maculopapular exanthema of her chest and neck, a bilateral conjunctivitis, ulcers in the mouth, bullous lesions, especially in the neck and the chest, and genital edema, and there was also bullous lesion in the genital area. So these are a few pictures of Julie at that time, as you can see. So if we look at what kind of hypersensitivity reactions we may run into in our clinic, of course, the best protocols and works the best in case of IgE-mediated reactions. And also there are strict contraindication for severe T-cell mediated reactions such as stress, Stevens-Johnson, TEN, AGEP, and hepatitis. Also, when we think about delayed reactions, there are few data in literature. Nevertheless, there are also some data of some centers who perform desensitization protocols in case of severe type 4 reactions. So in this paper, the authors induced a tolerance to antituberculotic agents in a patient who presented as Stevens-Johnson top 10 overlap syndrome. So they pre-medicated the patient with prednisolone, loratadine, montelukast, and ranitidine for 3 days, and then they started the protocol. The protocol lasted 3 days to reach the maintenance dose, and during the 3 days, they were able to reach a maintenance dose of 300 milligrams per day of rifampicin without presenting reactions. In this other paper, this was the story of a 5-year-old boy suffering from fever and a status epilepticus, and he needed phenobarbital. So the patient presented a DRESS syndrome with this drug, and then the authors administered him 6 doses with a 10-fold increase to reach the maintenance dose, and they were able to administer phenobarbital over 3 days and to treat the patients over a time of 5 weeks. Let's say there are exceptional cases and they're still a contraindication today to perform DSS. How about antibiotics? I said there are mainly beta-lactams for children. So the first peer review of hypersensitivity reaction to beta-lactams goes back to 1940s, when even the authors at that time were wondering what's going to happen if the patient who has presented already a reaction will need the same drug in the future. Well, the first extended experience on desensitization protocols to beta-lactams goes back to the 80s. So right now, we're in 2021, there are several published protocols on this topic. But there are also some protocols published for others antibiotics. Mainly there are case reports for these other molecules. I will tell you the story of Chloe. She was 14 years old at the time. She was diagnosed with cystic fibrosis at birth. And since 2015, she was chronically infected by Pseudomonas aeruginosa and Achromobacter zillozidans. In 2017, we diagnosed her diabetes and she was treated with insulin. And since 2019, she has having a gastrostomy. So we saw her because she was having a respiratory exacerbation with 3 main symptoms of fatigue, loss of appetite, and loss of FEV1. So we prescribed them the antibiotic treatment, the same one she's been having over the 3 last exacerbations, which included oral treatment with trimethoprim and 2 IV treatment with meropenem and tobramycin. What happens is that day 1, she was treated with trimethoprim at 6 p.m., followed by tobramycin at 6 p.m., which is a 30 minutes IV perfusion, and finally with meropenem at 6:30 p.m. Except that at 6:40, meropenem was still going, of course. She started experiencing a generalized urticaria with malaise, a drop in blood pressure, and so we stopped the perfusion and we looked for the culprit drug. So TMPSMX and tobramycin were negative at our allergy drug workup, Skin tests were negative for meropenem, but when we started the drug provocation test to meropenem, she experienced generalized urticaria at the first dose. So when we think about, there are several agents that are actually active against Pseudomonas aeruginosa. So we could just choose a different drug, except that for Chloe, well, as you can see, the R stays for resistant. So she has several resistance. But we could go, for example, with Astriana or colistin. But colistin, she was already taking inhaled colistin by powder every day. So that was not a valuable option. And for Aztreonam, well, Aztreonam could be a good option, but would not help us treating her Achromobacter. When we think about the protocol for beta-lactams, so antibiotics, we usually need to start at a dose that is 10 to the minus 2 to 10 to the minus 4 of the therapeutic dose. But if the patient had a severe reaction, we could actually lower the initial dose. The time interval between doses may be usually up to 15 to 20 minutes. And we could actually choose an IV, oral, or a combined route. And IV could lead to faster onset of potential adverse events. Well, on the other hand, oral route could be associated to slower onset of adverse reactions. For the dose increase, they are usually doubled. Sometimes actually slower increase at the beginning or in the final steps are proposed by authors. And if we think about the possible 10-fold increases, they should be avoided because it seems they are associated to more frequent reactions. So I will give you here 2 examples of protocols. There are several of them that are published, and each one of them is equally good if it's sustained by strong data. These 2 are for oral and intravenous, oral on the left and intravenous on the right. And it shows you the concentration of penicillin, therefore the amount of milliliters that should be administered and the dose in milligrams, and the cumulative dose to reach a final dose of respectively 800 milligrams or 1000 milligrams. How about NSAIDs? Well, the epidemiology of hypersensitivity to NSAIDs in children is difficult to assess. Probably through a child-proven exam, we could have a hypersensitivity rate between 8 and 68%, depending on the population, which is wild. The main drugs are actually ibuprofen and acetaminophen in young children, which are actually the most prescribed drugs in these age groups. And as kids grow older, all the other NSAIDs may be involved, such as ketoprofen, naproxen, aspirin, or diclofenac. In most cases, non-allergic hypersensitivity reactions are reported in children. Nevertheless, the sensitization protocol seems to be effective even in these patients. The problem is that there are no publications or good case reports published on children for these drugs. And also, pediatric allergists are not really used to do such procedure for NSAIDs in kids. How about chemotherapeutic agents and monoclonal antibodies? Well, they're usually used to treat autoimmune, neoplastic, and inflammatory diseases, and they have been increasingly developed and administered to the population and to the pediatric population as well. Therefore, we've been recording more and more cases of hypersensitivity reactions to these drugs. So when we have a drug hypersensitivity reaction, we cannot use the molecule. And so we should look for second-line therapies. But what we said before is that in those cases in which second-line therapies are not the best option for the patients, in that case, a desensitization protocol should be proposed. And it's quite interesting if you look at these molecules, as for example, in carboplatin, we have hypersensitivity reactions in almost a half of the children suffering from low-grade glioma. As for asparaginase, which is a common drug for acute leukemia, lymphoblastic leukemia, we have hypersensitivity reactions in about 40% of children. So the development of PEG asparaginase a few years ago could be helpful. With the limits today of the use of PEG and the possible associated reactions that have been described in patients, a few clinical cases, and today they are well looked at because of the presence of PEG in a common COVID vaccine. And as for monoclonal antibodies, we have been seeing in the literature several immediate and non-immediate reactions. There are a few papers in children for desensitization protocols. For example, here in carboplatin, indeed, in patients, pediatric patients with low-grade ileoma, the authors propose a 4-step desensitization protocol. Patients were pre-treated with steroids and antihistamines 1 hour before the protocol. As you can see, there were most of the reactions were grade 2 previously, and they provided patients with a dose of 1,000, followed by the dose of 1%, followed by 10%, and the rest of the therapeutic dose. And each dose perfusion lasted 90 minutes. With these protocols, nevertheless, they were successful only in 20% of their patients. So it didn't work so well. This other protocol proposed by my friend Pablo Rodriguez de Rio is a 12-step protocol for carboplatin. Kids were pre-treated with steroids and antihistamines, and they prepared 3 different dilution, 100 of the dose, 100 of the concentration, 1/10, and pure. So for each concentration, they provided 4 different doses, and the perfusion lasted 15 minutes for each step, except for the last one, the lasted 174 minutes, for a total of 5 hours and a half about of protocol. With these protocols, Pablo Rodriguez de Rio was able to have a success rate of 100% in his patients. So you can see as we change the protocol and we adapt it to our population and we do more doses, we start at lower doses, we can actually achieve a much better success rate. For L-asparaginase, in this protocol in which were included 9 children, it was a 5-steps protocol with a solution of 0.1%, 1%, 5, 10, and the rest of the therapeutic dose. The solution were diluted in 240 milliliters of saline solution, and each perfusion lasted 4 hours. So the overall protocol lasted 20 hours in this case. Well, once they reached the final dose, all 9 patients have been able to receive their following 2 to 15 doses of therapy with asparaginase. So here is another protocol in which they prefer a longer infusion to allow better tolerance. In this other one, they use 15 different steps to reach the final dose, and each step lasted 15 minutes, and the interval between doses was 15 minutes. Once again, you see 2 completely different protocols that might be effective. I'll tell you what we saw with one of our patients, Stefano, which was 14 years old at the time. She suffered from UC, and she had anaphylactic reactions, including skin symptoms and respiratory symptoms. 15 minutes after his 3rd infliximab therapy, he just ended it, and 15 minutes afterwards, he started presenting symptoms. Prick test and IDT were negative, but the provocation test was positive at the dose of 2.5 milligrams, which was 0.1% of the therapeutic dose. So what could we do here with a monoclonal antibody? One of the most common protocols is the 12-step rapid desensitization protocol with premedication, in which doses are administered with a 30 minutes interval. And you see here the example with the rituximab. So the problem is that with these protocols, the authors found that there were severe reactions during the procedure in 6% of patients, and they recorded 180 reactions in 413 patients. And more than half of them occurred during the final step. we don't really know the reason for which it was like that, but what we could speculate is that it was because between the 11th and the 12th dose, there's a more than a 24-fold dose increase of the drug. So for our patient, we actually used a different protocol that was published several years ago, in which every dose is administered every 15 to 20 minutes. And we start at a dose of 1/millionth of a therapeutic dose. And at every step, we have a 3-fold increase. So we start at 1/millionth to 3/millionth, then 1 to the 10 to the 5th, and et cetera, et cetera, et cetera. In that case, the increase between one dose and the following one is constant. So we use it and it was successful. And we actually use it currently for all our patients in the Montpellier unit. And we have very good results and very rare side effects. But we always achieve the final dose. How about the other drugs? Well, in adults, mainly are vaccines, neuromuscular blocking agents, or contrast media. For children, there are only data for vaccines, and they could be helpful to help us in this moment when there are so many patients suffering from hypersensitivity reaction to vaccines. Nevertheless, our current experience in the unit is that most of these reactions are not allergic, and we've not been needing to perform desensitization protocols so far to any of our patients in Montpellier. So what are the take-home messages from today's presentation? Indications. There are very few indications in children. We have shown them all. And it should be really kept in mind that these are very good indications, and we need to pay attention when we have a patient who has certain diseases and presents hypersensitivity reaction to drugs, and we need to be able to propose to these patients this kind of treatment. The drugs, for which drugs, we said it's antibiotics mainly, chemotherapeutic agents, monoclonal antibodies, and vaccines. Why not NSAIDs if there are possible publication, possible data in the future? NSAIDs will be surely included in this list. They're safe. They are safe. Desensitization protocols has proven to be safe. And actually, the reaction reported by patients during the protocols are milder than the one presented during the reactions most of the time. Also, for the protocols, the desensitization we started at a very low dose, and the increase from each step is different. So what we need to say is that there is not one protocol which is actually better, way better than the other, but each protocol should be adapted to what you're used to do and to your population. And finally, guidelines. There is a lack today of standardized protocol in children, and specific guidelines are missing on this specific topic. Thank you very much for your attention.
Muchas gracias. Excelente presentación del doctor Dave. Y a continuación, me pones la que sigue, por favor. Gracias. Tenemos el gusto de contar con la presencia de la doctora Maja Mockenhaupt. Ella nos hablará sobre reacciones graves a medicamentos, sobre todo Dress y Steven Johnson. La doctora Maja, me pones, por favor, su currículum. Ella comenzó sus trabajos sobre reacciones adversas cutáneas graves en 1990 como investigadora del Departamento de Dermatología de la Universidad de Freiburg, Alemania. Trabajó en el proyecto RESISCAR y el registro alemán de reacciones cutáneas graves. Ha trabajado en diferentes unidades clínicas del departamento, incluida la dermatología quirúrgica, y actualmente se desempeña como dermatóloga con obligaciones docentes y médica senior, gerente o subdirectora del Departamento de Dermatología. También ha ocupado el cargo de profesor en la Facultad de Medicina. Entonces, los dejo con la doctora Maja para esta gran presentación.
Very much for giving me the opportunity to speak about severe reactions to drugs this evening. I will focus on Stevens-Johnson syndrome toxic epidermal necrolysis on one hand and drug reaction with eosinophilia and systemic symptoms on the other. I am a dermatologist at the Department of Dermatology at the University of Freiburg, and I'm a professor there, and I'm serving as the head of the German registry for severe skin reactions and the coordinator of the International Regiscar study, but I'm a full-time employee at the university. I personally do not have any conflict of interest in regard to this talk, but in addition to grants from European Commission and other research institutions, we also had contracts with pharmaceutical companies who supported our work in drug safety. I'm currently a member of the advisory boards that are listed here, but they are not in any context with this talk. Now, let's get back to severe cutaneous adverse reactions or short-term SCAR. They lead to hospitalization or prolongate an in-hospital stay. They are rare but life-threatening conditions. They are unpredictable in occurrence and often also in outcome. And they require a multidisciplinary team for diagnosis, treatment, and causality assessment. And they are, in a way, all T-cell mediated reactions that occur during the first continuous use of a medication without earlier sensitization, except for one, and I will point this out. Now, first I will focus on the blistering conditions that I mentioned, Stevens-Johnson syndrome, TN, but also generalized bullous fixed drug eruption. Now, SJS-TN are sometimes also nowadays called epidermal necrolysis or epithelial necrolysis, covering the entire spectrum. Because we think, and it has been shown in studies, that there may be a progression of disease and Stevens-Johnson syndrome may progress into TN. So it's one disease entity of different severity. Typically, it starts with kind of confluent macules and flat atypical targets, as here, and then there's blisters on these lesions that are also confluent and lead to larger areas of skin detachment. The same happens at the mucous membranes. As you can see here, the skin is involved, but also the part of the eye here, the conjunctiva, lips, and genitalia. Atypical targets and macules, widespread, confluent. This is the typical picture of Stevens-Johnson syndrome in a 16-year-old girl. Here we have blisters and erosions of less than 10% of the body surface area. But I tell you, it's not easy to count these blisters and these lesions, since you have to consider they all, for example, get together and make a certain amount or percentage, and 1% of the body surface area, the patient's area, is 1 palm. Now here you may have progression in this child leading from Stevens-Johnson syndrome to what we call overlap condition, to TEN, with 10 to 30% of skin detachment. And here, this is more than 30% of the body surface area detached in this young lady. Now, the entire trunk would be 35, 36% if it is denuded. So it's more here. The diagnostic methods you would use is first check for positive Nikolsky sign. A tongue test can be done, or better, cryostat diagnostic. Certainly conventional histopathology based on a skin biopsy, and in some cases with atypical pattern, prolongated course, maybe also immunofluorescence tests. We always do it, we recommend it, but I know it is not always done. There's no specific laboratory parameters who would tell you, or which would tell you this is TEN. Now, this is the Nikolsky sign. You move this little wooden stick here or your finger across the skin, not with much pressure, just a little, and you see that the epidermis is detached. But if you look closely here, you see already little crusts that are an indication that something more than an exanthem is going on. Now, this is the progression in this patient after 12 hours, and this is after 48 hours. And you never know whether it's going to stop here or progress to this part in severity. In the histopathology, you have necrosis of the epidermis. This is the first thing to happen. And due to the necrotic epidermis, there's detachment of the epidermis from the dermis, and you have a subepidermal separation. Now, you can have that histopathology as well if you took the biopsy right out of the little necrotic center or blister of a typical target in erythema multiforme. So you always need the clinical correlation and the histopathology result. Now, in erythema multiforme, you have in the typical form these so-called typical concentric rings, the targets, mainly on the limbs, often associated with herpes, frequently recurrent, mostly in adults and less frequently in children. In children, you may also see typical EMM, but usually more widespread, not just palms and soles. And the second M for majors is for the mucosal involvement. But the pattern can be different as well. So here you see the typical targets widespread on the trunk, but they are disseminated. It's not a confluent exanthem that you would see here. Sometimes you see giant targets, like in the next picture here, and that you could consider could also be something else. Could be fixed drug eruption on the first glance, but this started as giant atypical targets and the mucous membranes are severely involved. So this is also EEMM in a child. Fuchs syndrome is based on the ophthalmologist Fuchs, who more than a century ago observed this pattern in the eyes and oral mucosa. And it was used then for the lesions or for the reactions that were limited to the mucosal surfaces. Nowadays, we have been able to show that atypical EMM is actually what we see here. So it's the pattern of the mucosa in EEMM, often without skin lesions, sometimes with, and the recurrent cases could change. So again, this is not Stevens-Johnson syndrome. Now, again, erythema multiforme versus SJS. You see here the child with EMM, often induced by mycoplasma in children, and TEN, mainly induced by drugs, although not so much in children, but I will come to that. Fixed bullous drug eruption could be a differential diagnosis too, especially when there are bullous lesions, and typically these bullous areas, they remain in the red patches and do not extend over these margins. So you could have the same histopathology also in children. Or here again, another case of generalized bullous fixed drug eruption, blisters in certain areas. And if it's the first time and just started, you would not see the typical pigment changes in the histopathology and had the same pattern, which is round and oval plugs and dusky violaceous brownish color. A negative Nikolsky sign on the normal skin. Hardly any mucosal involvement, rarely fever and malaise. But if it's a recurrent event in elderly patients, then it can be severe as well. Typically, this is different from SJS-TN. This is something you could call allergy because there is a sensitization and that is followed by the event. And it is due to the T cells that remain and do not go into apoptosis and then recognize the antigen again. Most frequently, we see it's caused by metamizole and cotrimoxazole or paracetamol in children. Another differential diagnosis is Staphylococcus scarlet skin syndrome, like in this baby, but you may already see that the skin detachment is very superficial, and here as well, the redness is some staining, but here you see it's almost dry, so very superficial. And this is a different histopathology, and even for the non-histologists among you, this is still epidermis, so this is a subcorneal separation and easy to differentiate. SSSS is caused by a Staphylococcus type. It's an exfoliative toxin that causes the pattern, this intraepidermal blistering, and you have rarely mucosal involvement, and it needs, of course, the appropriate antibiotic to be treated. It is very rare in the extensive form, so only 1 to 2 cases in 10 million people per year. Compared to that, SJS/TN is a little bit more frequent, although very rare, with 1 to 2 cases per 1 million per inhabitants per year. The mortality is high and related to the amount of skin detachments. So this is all patients, all age groups, and the mortality is high. Overall, it's about 25% due to the fact that there's more milder than very severe cases. But if somebody has TEN, more than 30% of skin detachment, and is older than 65 years, the chances to survive this are very low. For children, however, this is much better, even if they are severely affected by the disease. The death rate is very low, less than 10% in children and adolescents younger than 18. And if you just looked at this last column here, it's a study over 7 years where we looked at the occurrence of SJS/TN in the population. You see the different age groups here, and this is not just the number of cases, but it is compared to the age group or in the population in Germany. So you can see that 80 plus, so 80 years and older here, is the highest incidence of SJS/TN, whereas you have a very low one in the younger age groups. And this was recently confirmed by a study that we did. It was published last year, and you see the incidence is low in the lower age groups and high here. Now, what to do in terms of therapy if you have a person like this? Obviously, this young man needs intensive care because all his skin, almost all, has been peeling off, and that leads to other complications. And the first thing you always read in the books is stop the inducing agent, stop the drugs. So, but what is the drug? So we have to know a little bit about the drugs in SJS/TN to be ready to stop the right ones. The study that I just mentioned on the previous slide, the Euroscar study, done several years ago, was able to identify these drugs to have a high risk for SJS/TEN. So some of them you will see are not really used by the pediatric population, but some of them are. So mainly the antiepileptics, and sulfasalazine is also used, less frequently some others listed here. And this is the pattern of use that has been observed. So these were young people with lamotrigine-induced SJS/TEN, and none of them had used the drug for less than a week. And it was for all of them the first continuous use of lamotrigine that led to this reaction. So that means on average, the drug was used 2 to 3 weeks without any problems, and then the reaction occurred. And this is the typical pattern of drug use causing SJS/TN. Other drug groups have also been observed. There was a moderate, although still significant risk for these groups, but we could not go in more detail for the individual drugs due to the numbers, although there were almost 400 strictly validated cases included in that study. The good news is that many of these drugs have been shown in 2 different studies to not carry an increased risk for SJS/TN. And this is especially due to ibuprofen and propionic acid type NSAIDs in children. And I will show you how this looks like, because they are often accused to cause the reaction on a false basis. And this is the early events in SJS/TN. It's a graph that is based on the total number of 379 strictly validated cases in that study. So not one case, but let's say an overall pattern of these cases. You somewhere here could observe the beginning of a drug use continuously. Then there's first symptoms. 2-3 days later, often the diagnosis is made, and then that leads to admission to the hospital. And here still there's progression of the disease. And at some point, the maximum detachment is reached, and then hopefully the reaction heals and cures. And this is the pattern of medication. And you could say, oh, this is very easy. So there's somebody who had this drug, which is sulfasalazine, due to colitis ulcerosa. And this person also had fever, was a 5-year-old child or a 4-year-old child, and fever and pain, sorry, this being in German, and that was given just shortly before the patient was admitted to the hospital. Now, even if you decided here is target lesions, fever and pain, and with the target lesions, the reaction starts, it's a couple of days before the erosions of mucous membranes and before the patient was hospitalized. Within the couple of days before, maybe there's already some prodromal symptoms, and you want to make sure that your drug, as I showed for lamotrigine, is taken in the relevant time period. Started recently, going all the way to beginning of the reaction or hospitalization. And this is true for sulfasalazine. So very easy, this is the culprit one, but it's not always that easy. Look at this case. More complicated, developed in the hospital and took a lot of medication or was given a lot of medication. And even if you put your lines here for the index day, so the reaction onset, and you're helping lines to see that the drug should be present in the body in the relevant time period, it may be difficult to tell which one was it. But Alden is an algorithm to help in this case, but it has to be used strictly for each drug that has been taken or given before. And if you use it, perhaps in the end, you come up with phenobarbital to be the inducing one. So the algorithm helps to identify the culprit drug based on the information of the studies that we have, the risk of the drugs, which we call drug notoriety, recent start of drug and intake and prior use or not is very important, and the relevant exposure window from about 4 days to 4 weeks before reaction onset. But the half-life of the active substance is also important in this context. And when infection are present, there might be a confounding by infection or confounding by indication because there may be antibiotics or antipyretics taken to treat the infection. And at the same time, they could have induced the reaction or the infection could have induced it. And it's even more specific when it comes to fever and malaise. as prodromal symptoms, because this period may lead to a wrong assessment. We call it protopathic bias, and that means that the analgesics and antipyretics that are taken to treat the prodromal symptoms are often considered to be causing the reaction, which we think is not correct. And this is mainly analgesics, antipyretics, and secretolytics given to treat these first symptoms. But if they have been used multiple times and have always been tolerated, and very shortly before the objective signs, then it's highly unlikely and they cannot be accused to have caused the reaction. And this accounts mainly for these drugs listed here, paracetamol or ibuprofen. And we have to keep in mind that 25% of the TN cases of all age groups are not drug-induced. They have other reasons, infection or something we don't know, but not drugs. And in children, this is about 50% of the cases of SJS/TN that are not drug-induced. Here also an example for the protopathic bias. This is from a pooled analysis of the SCAR and EuroSCAR study. And here acetaminophen paracetamol is looked at, and you see that here now is the beginning of the reaction very shortly before this drug was used. And if you just look at those that have been taken for a longer period, and these ones, the dark ones, had other inducing agents, so-called highly suspected drugs, there's not much of a risk for paracetamol. There's not much. Now, other therapies besides stopping the appropriate inducing agent, for example, immunomodulating therapy. What is the current standard there? I cannot go through all the studies and details, but I will at least show you what we recommend over here for our patients. And this has also been shown in a study, a meta-analysis of cyclosporine treatment in SJS/TN that was performed in Singapore 2 or 3 years ago. And this meta-analysis of 9 studies revealed a significant reduction in mortality risk with cyclosporine therapy. And this is the graph of that study. And we know there's a few case reports, but we are actually now analyzing the cases, the patients that have been treated with cyclosporine in Germany, and we're very much looking forward to those study results. But our impression is, and also from the patients we've treated here, that it's very helpful. And the reason may be the mechanism inhibiting T cells and probably also cytokines, if not yet released, and thus opposing the apoptotic pathway in non-lesional skin. So preventing the still normal skin to go into this detachment phase of necrosis. And it seems that cyclosporine A is not able to stop cytokines that have already been released. So this might be a reason why to start it early on, because later it probably would not be helpful. And again, this graph, you know it. So when the diagnosis is made clinically, histologically, and it's clear it's SJS/TN, then we recommend to start the cyclosporine. And there's a few reasons why not to give it, because it's only given for 10 days in a row. 3 milligram per kilogram body weight for 10 days. That's what we recommend in patients or in cases that have progressed with the disease in the past 24 hours. If there's no progression, there's no need to do it. There's also very much importance to be put in supportive care. And this list here is taken from the French Center for Toxic Bullous Dermatosis. And they have provided a good compilation of what needed or what needs to be considered, like this evaluation of diagnosis, and is early on the most important, but who needs to be involved, which parts of the body are involved, the multidisciplinary team, and so forth. Everything has to be evaluated. And then they suggested a flow chart that usually detachment of less than 10% of the body surface, no specific center is needed, but if it's more, it should be a specialized center. Specialized center can be dermatology, can be pediatrics, can be, if more skin is detached, a burn unit. And then there's many things you have to consider in cases with large amount of skin detachment, as is summarized here, from nutritional support and fluid resuscitation, then management of acute respiratory failure, local skin tear, and ophthalmologic surveillance. That is very, very important. And later on, if the patient hopefully managed everything very well, then you can do tests to confirm the drug course, but not really so much in SJS/TN. The patch test is not very helpful. We do not recommend it because it doesn't lead to anything with this low rate of correctly positive results. In GBFDE, yes, it's very helpful, and you can do it in local or at the back as usual. Some of our colleagues have successfully used lymphocyte transformation or stimulation tests to confirm the inducing agent. But this is a very special thing. You need experience, researchers and laboratories to do that. It's a very, I would say, specialized thing, and it's not in routine diagnostics so far. But there's more tests that are developed by different groups at the moment. Many of you may have read about the fact that certain HLA alleles are related to certain type of reactions. This is true, but it's not only reaction type in HLA, it's also related to the inducing drug, what we know so far, and is related to ethnicity of the patient. So it's rather complicated. And just the example of carbamazepine, you may find it, this certain allele, HLA B1502, for SJS/TN induced by carbamazepine, but only in Southeast Asians, not in Europeans, and not in Japanese, and not in Koreans. And HLA B5801 and allopurinol, they can be seen in different populations. In Europe as well, although to a lesser extent, as in Southeast Asia, but it is of relevance. In DRESS, we do not know yet in Europe. But not so long ago, we were able to find the HLA allele that is related to carbamazepine-induced SJS/TN in Europeans. It's not as strong as the signal for Asians, but it's something to look for. But it's not a diagnostic test yet. It could in the future be a preventive test, as the test for HLA B1502 is in Hong Kong and Taiwan before prescribing carbamazepine, but not yet in other populations. Now, in the end, I would like to also speak about DRESS. I called it systemic condition because there's different names for it, but it's all involving internal organs and not just the skin. So I think in most of the countries nowadays, people speak about DRESS when they talk about a condition and not about other, or do not use other names that have been suggested. It's only in Japan that the term drug-induced hypersensitivity syndrome is still used. Now, as I mentioned, it's a multi-organ disease. It's drug-induced, as the name suggests. It is accompanied by fever, rash, and changes in the blood count, eosinophilia, atypical lymphocytes are there, lymphadenopathy, and involvement of liver and other organs. But to be honest, you can have that together with such a sort of rash in many conditions. So it's also a diagnosis made by exclusion of other conditions. Here you see this in a child, and you easily recognize that this girl is not in good shape. She is feverish. She has swollen face and edematous body, scaling dry skin, but some lip erosions. In here, even some target-like lesions. And if you look at her story, it started with a cough and fever. Everybody thought this is infection. The skin was itchy, there was an exanthem, and there were lip erosions. Then she was taken to the hospital, admitted, and there was interstitial pneumonia. Not something too often seen at that age. And then edema, hepatomegaly, and further issues. And it took a month till she was discharged. And if you look at the dates here, you see eosinophilia was present on October 20. October 24th, you saw 16 times elevated liver enzymes, but eosinophilia was already normal. And another day later, you saw further changes concerning the liver. So that means you have to take the blood samples repeatedly, otherwise you will not detect the problems. So this is important. And then you have to follow the clinical pattern, whether you have to look for involvement of the heart, of the kidney, and so forth. And of course, also a serologist should be taken to exclude other diseases that could pretend to have a pattern of stress. And HHV6 is also important, and I will come back to that in a minute. Skin biopsy should be done to exclude other conditions, but it's not very specific. Now, there's a score, the DRESS validation score that was created by the Regiscar study group, and it gives certain points to certain involvements that are present, but it's important to use the score correctly. For example, the liver can only be considered as involved if the liver enzymes are elevated more than double the normal value at 2 different dates, and it's similar with kidney. Now, we have analyzed about 200 cases, potential cases of DRESS in the Regiscar study a couple of years ago, and with strict validation, you see that only a certain amount, 60% or so, were considered to be probable and definite, and they were analyzed in the study. There were more women than men, but interestingly, the women had a significant lower median age, maybe due to certain medications, but we are not 100% sure. Fortunately, the death rate was very low, but the disease is still quite a challenge for those who have it and those who treat it. The organs that were involved were mainly the liver, 75%, and then followed by kidney, lung, spleen, muscle, and heart. The majority of patients had eosinophilia, 95%, and others atypical lymphocyte. There was no patient in this group who had not at least one of those. And it usually lasted, the disease lasted more than 15 days, often much longer. The inducing agents we found on the entire population were carbamazepine and allopurinol in almost 40% of the cases. They were causing these reactions. In children, you hardly have any allopurinol use, but you find carbamazepine, phenobarb, oxcarbazepine, lamotrigine, so mainly those drugs that are given for seizures or epilepsy. And if you compared DRESS and SJS/TEN induced by carbamazepine, you still see a difference because the darker red here is SJS/TEN cases after the use of carbamazepine. And you see the time latency between beginning of drug use to the onset of the reaction. Whereas this is much longer for the DRESS group caused by the same medication. So the mean time latency for DRESS caused by carbamazepine was 26 days with a wide range, as you see here. And it was about 15 days with a much smaller range in SJS/TEN. And I told you I wanted to come back to the viral reactivation. That is something to be observed in DRESS cases, in severe cases, rather frequently. Even in adults, it's a reactivation of HHV6 or other herpes viruses. And that may indicate a prolongated, more difficult course of the disease. So therefore, it's important to check it. And it may also help you to modify the treatment accordingly. The treatment, there's no studies actually, but immunomodulating treatment has been suggested to be systemic corticosteroids at first, so as a primary therapy, as a kind of a gold standard in the clinical setting. And usually it's suggested to give a 40 to 50 milligram tapered over 6 to 8 weeks. This is what the Japanese colleagues suggest, but it could be like 1 to 2 milligram prednisolone equivalent per kilogram body weight. So it's more of an individual judgment, to be honest. And sometimes this has to be given over a longer period of time, especially when there's flare-ups. And if there are flare-ups of the disease, you should always repeat the HHV6 test. And in some patients that did not respond to systemic steroids, cyclosporin has been tried, but so far there's no big studies on it. I know one is done or underway at the moment, but we do not have these results yet. And other immunomodulating therapies have been reported in certain cases, but they actually recommend yet. And there's also a score that may help you to separate mild cases from moderate and severe cases and how the treatment could be. So it might be helpful also for tapering the steroids. And this was done by our Japanese colleagues. Now, what to recommend here? As I mentioned, the severity score should be applied, corticosteroids first choice. And you may use this volume, or depending on the patient's situation, the dose, and then this is slowly tapered. If, for example, CMV is positive, it had been suggested to use an antiviral treatment. That is not so much with a viral reactivation, but more also with CMV acutely present or very high levels. And then you may use an antiviral medication for that. There's certain protocols also developed by the Japanese colleagues, and you could use them. A patch test can be done safely 2 to 4 months after the healing period of the disease. And here you have much better results in the patch test. About 60% are correctly positive. Not for allopurinol, it never works in a patch test due to the molecule size. LTT or LST can be done similarly. And with that, I would like to thank you for your attention and wish you a great and successful further meeting. Thank you very much. And for any questions, do not hesitate to contact me under these address modalities. Thank you and goodbye.
Muchísimas gracias y gracias por los comentarios en el chat. Sí, creo que fueron 3 días de mucha ciencia, de muy buenas pláticas, y lo más importante es que todos lo han disfrutado y que sobre todo le vamos a obtener el mejor provecho para nuestra práctica cotidiana. Y continuamos ya con la última sesión del Summit. ¿Me puedes poner, por favor? Gracias. Tenemos el gusto de presentar al doctor Paul Whitaker, que nos hablará sobre reacciones retardadas a medicamentos. Fue un gusto poder contar con él porque en un inicio estaba muy participativo y después no pudimos tener mucha comunicación con él y al final volvimos a tenerla. Entonces, es un agrado. El doctor Paul Whitaker de Inglaterra, él es consultor respiratorio del Reino Unido con un interés especializado en bronquiectasias e infecciones pulmonares. Durante varios años ha desarrollado un interés en la investigación de hipersensibilidad de medicamentos, particularmente en el campo de las reacciones de hipersensibilidad de antibióticos no mediadas realizadas por pares relacionados con alergia a medicamentos y respuesta inflamatoria en pacientes con enfermedad respiratoria. Excelente, y continuamos, por favor, Alfonso.
So good evening, my name is Paul Whitaker. I'm a respiratory consultant from the UK, and I've been asked to talk to you about the management of patients with non-immediate reactions to drugs, but in particular antibiotics. I wanted to talk a little bit about how to assess people and then more about the management of these patients, including desensitization. I'm going to focus a little bit on cystic fibrosis, as this is an area familiar to me, but it's also applicable to other conditions such as COPD. So in cystic fibrosis, there is a high frequency of chest infections requiring antibiotics. Patients often have 4 or 5 courses of intravenous antibiotics every year. And as they grow older, they have more complex infections. So, for example, Pseudomonas aeruginosa is an organism that frequently causes more exacerbations of the chest, requiring nebulized oral and intravenous antibiotics. And what we find is patients, especially as they get older and sicker, develop more and more reactions to the antibiotics. Now, as you know already, these reactions can be split into immediate and non-immediate reactions. And in cystic fibrosis and in other respiratory conditions, most of the reactions we see are non-immediate, happening typically more than 24 hours after they start the drug. Most of the time, these reactions are quite mild, with skin rashes, macular papillary eruptions, maybe some delayed urticaria, but they tend not to be severe. And it's very rare that we see bullous skin reactions or see reactions with other organ involvement, such as the liver or hemolysis or other blood disorders. And it's very common. So in these 2 studies here, 36% of patients in the first study from Australia, 36% had reactions, 19% had multiple reactions. And then in the study from Berlin, 60% had a reaction to an antibiotic, with 31% to 3 or more antibiotics. And in each study and in other studies, the commonest antibiotic group causing reactions are beta-lactam antibiotics. And certainly in our experiences in Leeds, we have similar, where around about 1/3 of our patients have had reactions to the common beta-lactam antibiotics such as ceftazidime or piperacillin. And this is kind of a typical rash we see. It's not something which is life-threatening, but it's often sufficiently uncomfortable for the patient to want to stop treatment. When you biopsy these, you see this perivascular lymphocytic reaction in keeping with the non-immediate T-cell mediated reaction. And these patients have reactions, and COPD patients have reactions because of the multiple number of courses they have, and the very activated immune system they have. So when the immune system is switched on from an inflammatory point of view, it's much more primed to have an allergic reaction. In cystic fibrosis, the patients often have high doses of antibiotics, and they have them intravenously, which is more stimulatory to the immune system. And they do matter. When patients have reactions, you often have to give them less effective combinations, which are often more expensive and often lead to other complications such as MRSA or C. diff diarrhea. And a lot of these other antibiotics also have to be given in hospital and can't be given as home intravenous treatment. It does lead to a lot of anxiety, and many patients, for many patients, it becomes one of the biggest problems, the anxiety about intravenous treatment. So when you're assessing a patient for drug allergy, you follow the same algorithm each time. And on the right-hand side of this figure here is the management for non-immediate T-cell mediated reactions. So the first is always to take an effective history. A lot of the times, problems such as headache or diarrhea or other issues can often be discounted without further investigations. Next, you would go on to skin testing and in vitro testing. Which order you do those doesn't really matter. Before going on to provocation testing, if everything else is negative. And in provocation testing, you're exposing the patient to the drug in a stepwise fashion, often giving a low dose and building up over a short period to see whether the patients can tolerate the antibiotic. The provocation test will often identify sometimes up to 7 or even 10% of patients as having hypersensitivity when all the other tests have been negative before. So first of all, taking the history, this is important. Very frequently on paper records, things are just not recorded properly. The symptoms are crossed out and it becomes very unclear. So when documenting, always document the reaction, the date, the time, the timing of the reaction, the symptoms, other drugs at the time. Have they had the antibiotic since? Because a lot of patients will be allergic to amoxicillin, but have had it several times since. And we often have to pull this together from different sources to get proper background information. For non-immediate reactions, the commonest skin test used is the intradermal test. You'll inject under the skin and then read at 24, 48, and 72 hours. And if you have this delayed erythema with the infiltration being greater than 5 millimeters, you can consider that positive. The problem is, certainly for beta-lactam antibiotics and non-immediate beta-lactam antibiotics, the sensitivity is very low. So in children who had proven provocation tests, only 2 out of 22 had intradermal positive readings to beta-lactams. And Romano et al. In 105 patients who had positive provocation tests, only 1 out of 105 had a positive intradermal or patch test. And we found something similar. We had 50 patients who had positive lymphocyte transformation tests to piperacillin, but only 8% had a positive skin test. So skin testing, we don't really do much anymore just because the sensitivities are so low. The lymphocyte transformation test is more complicated and intensive. However, we've had sensitivities of up to about 60–70% with the lymphocyte transformation test. It involves taking the patient's blood cells, and the yellow cell here is a drug-specific T cell, mixing it on the plates with antibiotics and allowing it to culture for about 5 days. And what you can see is if the drug-specific T cells are present and they're exposed to the antibiotic, they'll proliferate, which you can measure with radioactive thymidine. And you can see in the center here, as this patient who is hypersensitive to piperacillin, as you increase the piperacillin concentration, the drug proliferation also increases, showing that the patient is hypersensitive compared to naive and tolerant patients. Now, for immediate reactions, people often lose their allergy over time, and this old study from Spain shows that after 5 years, patients who were hypersensitive to amoxicillin lost their immediate sensitivity after 5 years. With T-cell mediated reactions, that's much less likely. We've had patients who had reactions 20 or 30 years ago who we can still find being positive with in vitro tests and when they're exposed to the drug. But by working up these patients properly, you can exclude a lot of patients who are not hypersensitive. And in this recent study in France, 70% of patients were excluded as being allergic once they'd had skin testing and a drug provocation test. So the journey to a potential desensitization involves a thorough allergy workup first. And even when you get to the point of proving allergy, you would still explore the possibility of giving alternative drugs first before desensitization. And a lot of the time, these are the common drugs we use in cystic fibrosis, but a lot of the time the reactions are, again, side chains, and patients can often readily cross between different drugs without any cross-reactivity. The one exception often is ceftazidime and astrionam, which share a common side chain. But as you can see in this figure here, and we'll just look maybe at the left-hand one because the other ones show something similar. But you can see here a patient, this is a clone of a patient, which is sensitive to piperacillin. So these dots here represent activated T cells, and this is the ELISpot test. And down at the bottom, these black lines here represent piperacillin, and we're getting a strong piperacillin response. But what we can see is that with meropenem and astrionam, you're not getting any response. So these clones and the patient's reactions are very much against a single antibiotic rather than cross-reactivity. But sometimes we do get to the point where there are no alternatives. The patient has exhausted all beta-lactams, or for other drugs such as tuberculosis, we may be restricted in what we can give, or certain chemotherapy agents may also be essential for the treatment of that condition. Now, this is becoming less common as drugs evolve and more options are available, but sometimes this is still the case. So in this situation, we do drug desensitization. And drug desensitization is when you induce on a temporary basis, so it's induced temporary tolerance to a drug responsible for a reaction. So you're not trying to provoke the patient or do some kind of graded challenge. This is where you're trying to have a strategy to avoid a patient who is known to be hypersensitive reacting. So you perform it when the drug is absolutely essential, when there's no alternatives, when the previous drug reactions were not severe. So you wouldn't, for non-immediate reactions, you wouldn't try and do it for patients who had severe skin reactions, bullous skin reactions, or liver involvement, or blood abnormalities. You would only do it for patients who had milder T-cell mediated reactions. And there's different ways of doing desensitization. So for the non-immediate reactions at the bottom, you can do an oral desensitization over several days or weeks if the drug is available orally. Intravenously, we tend to follow a similar pattern to the normal desensitization, where it's actually quite rapid over several hours. And this is just one example of a desensitization. So at the top here, we start with ceftazidime at a dose of 0.0036 milligrams. And every step, and there's 7 steps, every step goes up by a factor of 10 until the final dose is 3.6 grams, which is the therapeutic dose. Each step lasts for about 20 minutes. So overall, it lasts for about 2.5 hours. The second way of doing it, which is probably the correct way of doing it, is to have 3 different solutions. So solution 1 has a very low concentration, solution 2 a little bit higher, and solution 3 higher still. The first 4 steps are with solution 1, the next 4 steps solution 2, and you increase the rate between each of the steps. So between 1 and 2, 2 and 3, 3 and 4, increasing the rate before switching the bag to a higher concentration. Now, the advantages of this one is you can speed it up or slow it down or go back a step, depending upon how the patient is doing. But typically, this desensitization would last for just under 4 hours. When we do drug desensitizations, bearing in mind we do them in low-risk people, we do it on a medical ward with 1-to-1 nursing, and the patient is closely observed with observations every 20 minutes. And once the desensitization is complete, we keep the patients in hospital for 48 hours before going home, as if they're going to fail the desensitization. It happens in the first 48 hours typically. Now, desensitization, as you know, is typically for immediate reactions, and there have been several studies looking at the effect of desensitization in immediate reactions in patients with cystic fibrosis. So this is one of the early papers from 1984, where they had 13 out of 15 patients who were skin test positive to beta-lactam antibiotics, and 96% completed the 7-step regimen successfully. And then again, a little bit later, Turvey et al. Used the different approach, the 12-step regimen, and again, they had 75% successful procedures. So it is something which can be effective in this group. Again, for immediate reactions, there's a logic to it. The feeling is that the desensitization process inhibits mast cell degranulation. So often patients' skin tests will become negative after desensitization. When people have been desensitized multiple times, they often almost develop some tolerance to the drug, and often shorter desensitization protocols can be used. And when you look at immediate desensitization, you do see a rise in regulatory responses. So interleukin 10 and CD25 regulatory cells are involved in the regulatory immune system, and suggests that you have this counter process to block the immune mechanisms. Now, for non-immediate reactions, it's not quite so clear in terms of desensitization, but this is a typical case of what we see. So we have a young female with cystic fibrosis, chronic Pseudomonas, and a lung function of 20%. And for various reasons, mainly allergy for the beta-lactams, but also side effects due to the tobramycin and the colomycin, they have very limited treatment options. So this kind of situation where we have very limited treatment options, we'll often desensitize. And when you look at our success with desensitization in non-immediate reactions, this is from about 10 years ago when we published this, around about 45% of patients would fail with tazocin, and something similar with the other antibiotics as well. So these patients did frequently fail desensitization. When they did, it was often a reaction that was similar to what they had before, if not a little bit milder, because it's a more controlled environment. And pre-medication with steroids or antihistamines didn't really make any difference in the non-immediate reactions. What we did see when we did look at some of the patients who were successful is we were able to, just on the bottom left here, this is a patient who had an acute reaction to piperacillin. We then checked their lymphocyte transformation test before desensitization, and we had a nice positive result before desensitization. And then on sample 3, this is just after desensitization, and sample 4, 24 hours after. And we've got a normalization of the lymphocyte transformation test with the patient tolerating the drug. When we look 8 weeks after desensitization and they haven't had the drug for a period of time, you can see the response, the lymphocyte transformation response is back again. So they had a temporary tolerance with the desensitization. And you can give the drugs intravenously or you can give them orally. So this is a young girl who has nocardia infection and needs cotrimoxazole as part of her treatment. However, she's had 2 courses of cotrimoxazole in the recent past where she's had a rash on both occasions. And this just shows the damage the nocardia was doing to her lungs. And so what we did with her, because the cotrimoxazole was so important, is we desensitized her to the cotrimoxazole. Now this is one protocol which was used by Pascal Damely in France, where he increased the cotrimoxazole dose in a stepwise fashion. So the 12th dose was almost the therapeutic dose. And in 44 patients with HIV, he managed to successfully treat the majority with cotrimoxazole with this graded desensitization. For our patient, she also managed a similar protocol where we didn't have to rush it so quickly, so we did it over several days, but she tolerated the cotrimoxazole in the end and managed a full course of cotrimoxazole treatment for the nocardia. The other drug we frequently have to use is ciprofloxacin, and here we have a ciprofloxacin oral desensitization to allow the patient to tolerate ciprofloxacin. And again, for most drugs, there is a desensitization regimen available in the literature, and often it can be adapted to local situations or how quickly or how slowly you want to go through with things. And there is evidence to say that sometimes this oral desensitization can work. And here we have a patient who had a reaction to allopurinol. And the second one here was a provocation test to show that the patient really was hypersensitive to allopurinol. It was a fixed drug reaction here. And then finally, the patient underwent a desensitization regimen. And instead of having a red inflammatory fixed drug reaction, they developed more of a bruise during the course of the treatment. It was a 6-week desensitization ending up with 100 milligrams of allopurinol. And when they biopsied this lesion at different stages, what they found was that there was a significant increase in CD25 cells, which are again involved in immune regulation. So it looks like in non-immediate reactions too, if you give the drug at a sufficiently slow rate, you can allow the regulatory immune system to somehow keep everything else in check. Now, sometimes, no matter what you do, you'll end up with patients who have so many allergies that no matter what you do, even desensitizations, you're unable to treat them effectively. They'll often react during desensitizations. Now, in this situation, you've got a few options. The first one is if the reaction is mild, you can treat through. Now, this basically is allowing the patient to have a reaction. You can give them steroids or antihistamines or topical creams to make things more comfortable, but you're allowing the reaction to happen, knowing that it's unlikely to get more severe than it has done before. It'd be virtually unheard of for somebody to have a maculopapular reaction on several occasions, which then turns into something different. Normally, the reaction is the same on every exposure. The second option is something called continuous infusion. And with continuous infusions, instead of giving the drug, which we would do traditionally perhaps 3 times a day in high doses, what you can do is give a constant background dose of the drug. So this is the green dotted line here. You're giving a constant background dose of the drug to avoid these high peaks in the drug levels. And again, we've had patients who failed desensitization, but when we've given them instead just a low dose continuous infusion, they've often tolerated it quite well. And finally, you can look at alternative routes. For example, some drugs like astrionam are also available in a nebulized form. So you can give these drugs in different routes, and sometimes they may be hypersensitive intravenously, but they can tolerate things in a nebulized form. So in conclusion, managing non-immediate reactions is difficult. I think desensitization does play a role in the people with non-immediate reactions as well as those with immediate reactions. However, the data for desensitizations and the immunology around how we do it and the regulatory responses are still not very clear. And we all need to work together to try and put all these things together. So thank you very much. Thank you.
Muchas gracias. Tuvimos muy buena audiencia los 3 días, estuvimos por arriba de los 350 participantes. Agradezco que haya sido de su interés. La verdad es que trabajamos arduo para hacer este programa, la doctora Elizabeth Estrada Reyes y yo. Gracias, en serio, creo que es algo que nos apoya a todos. Aquí está ya la encuesta. Por favor, tómenle una foto al QR para que puedan contestar la encuesta y que tengan su constancia. Y en nombre del doctor Francisco Espinosa, de Guillermo Guaquida y un servidor, la doctora Eli también, les deseamos una feliz Navidad, felices fiestas, un próspero año nuevo. Y muchas gracias a todos por su participación y vendrán tiempos mejores. Mucha salud y gracias una vez más por su participación. Un abrazo para todos y síganse cuidando. Gracias. Gracias por todos sus comentarios y continuaremos haciendo muy buenos proyectos como siempre los hemos hecho. Muchas gracias a todos. Hasta luego. Perdón, nada más un mensaje final. las pláticas estarán disponibles hasta el 31 de enero para que las puedan ver y poder tener su constancia. Entonces van a quedar grabadas en el sitio de Compedia para que las puedan ver las veces que ustedes gusten hasta el 31 de enero de 2022. Muchas gracias. Un abrazo fraternal. Que estén bien.